coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people who call this land home. The Canadian Federation of Nurses Unions is located on the traditional unceded territory of the Algonquin Anishinaabe people. As settlers and visitors, we feel it's important to acknowledge the traditional custodianship of these lands, which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations, to work towards healing the wounds of colonialism, and to improving our own understanding of local Indigenous peoples and their cultures. Miigwech.
Bonjour tout le monde. Hi everyone. I'm Linda Silas. So happy. Whoops. I had to close my own translation, but that's a good point to remind me if you need translation, it is provided. It's at the end of the screen with the little globe. Just select French or English and we'll be there. So I'm Linda Silas, National President for the Canadian Federation of Nurses Union, and so happy to be here because we're bringing solutions. You know, I am very fortunate. We have experts working with us for many reasons, but one of the reasons is that, you know, the old saying, eh? Oh, here goes the union again. Oh, there, what are they lamenting about now? But when 1 in 2 nurses are saying, I want to change jobs, I want to leave, Saskatchewan, BC, Newfoundland, Labrador, it's 60%. When 86% of our members are showing signs of clinical burnouts, when you are seeing 4 to 6%, yes, when you're seeing ERs closing, families worried about their children's health, surgeries, backlog, you know what the problem is. And we also know that we do not need to be studied again. Nurses are fed up of being guinea pigs. We need solutions. And that's what our speakers are going to show us today. So if I could switch the slide, please. There. So that's our famous report. Next slide. This is our amazing 3 speakers, which we'll get at them in a sec. Next slide. So main message for us, it's about solutions. It's about one, knowing, as my friends in Newfoundland, Labrador say, we are broken. Nurses are broken in this country. We're beyond broken, but we're not beyond repair. So Ivy, Houssem, and Arthur are going to be talking about the solutions and how, yes, it's the systemic problem. It's the healthcare system as a whole. We cannot blame nurses. We can't blame healthcare workers for what's happening. But what we need to do is fix the system, and we need it to do with a pan-Canadian approach. So the first speaker today, where's Houssem? Was the main expert working on our report, and I think we can see him there he is. Houssem, if you want to start, please. And you can give your pedigree, and you're from Université de Montréal, and you work with Université d'Ottawa, and you're from Turkey, and you're a nurse, and all of that. You can explain it.
Thank you so much, Linda. Thank you so much for this introduction. Yeah, I come from Tunisia, but I'm postdoctoral fellow at the University of Ottawa, and I did my PhD in nursing from Université de Montréal. So let's start this first section. Please, the next slide. So as you know, like all health workers, with no exceptions, are caught in a vicious cycle. As you can see here, nurses, health workers, other health workers that are suffering from burnout, from depression, from even mental health disorders, going also to work overload and rising attrition. As you can see here, the cycle is vicious, and we are still stuck in the cycle. We cannot get out from the cycle. So what we need to move on and to sustain the nursing and the health workforce in Canada, we need reactive and proactive solutions. Let's start by reactive solution and what do you mean by that. In our report, we have identified the approach, the critical R's. The first one, retain and support, return and integrate, and recruit and mentor. As you can see here, we need to move from the vicious cycle to a virtuous cycle. So let's start by the first R. In the first R, we have focused on different issues that have been highlighted by our stakeholders and even in the literature. First of all, we need to reduce workloads. Nurses have been suffering from excessive workloads. And here we have suggested a number of solutions. Some of them, for example, to implement and legislate a nurse-to-patient ratio in different healthcare settings. And if this solution is not possible in different settings, like, for example, the residence home care, we can implement and legislate the minimum care standard. We also suggest to increase the flow team in order to support our nurses, to reduce their workloads, and to hire a range of health workers to reduce the non-nursing duties, like, for example, clerics, administrators, etc. We suggest also to implement a synergy professional practice model, and this model has positive outcomes and has been implemented in different provinces like British Columbia, Ontario, Saskatchewan, etc. In order also to foster a safe, healthy, and supportive workplaces for nurses and health workers, we need to improve the work conditions of nurses. We need to focus on this. It's very important, and implement a caring workplace that is free of violence and bullying. We may also implement a psychological health and safety in the workplace standard, so we can foster safe, healthy, and supportive workplaces. As you know, many nurses have been suffering from burnout, and CFNU have conducted a number of surveys and national surveys and have raised that this is a critical issue. So in order we need to support mental health of nurses and health workers by dedicating mental health days to re-energize themselves. We need also to embed peer support programs, make accessible target internet-based cognitive behavioral therapy if it's not accessible in person. So we need to support the mental health nurses in order to continue working and also provide high quality care to other patients. Also, we have thought about the career path. Nurses, when they graduate, they need to know and they need to be supported from grading, from entering the nursing workforce till retiring. This is very important. And here we have suggested a number of solutions across the career path, including a residency program that can facilitate the integration of new grads in nursing profession until the retirement. Like we have suggested also to facilitate the access to continuing education, implement mentorship programs, flexible scheduling for nurses. And also we can implement the 80-20 models, which has a positive outcomes on nurses and even health workforce. So now if we move to the second R, which is return and integrate, we have focused on three topics. First of all, we need to return our nurses who left the public system to work in agency. We know and recognize that many nurses, they can wonder, we don't want to return to public sector. We understand that. But we need to implement the work conditions in a public sector to return our nurses to the public sector. Here we suggest to implement a magnet-like accreditation program, which is a gold standard that has been positive outcome in USA, for example. We need to improve wages and benefits and also create a public agency for mobile nurses, etc. The second point, we want to return the recent leavers and early retirees. Here we have suggested a number of solutions, including support a flexible return to practice program. This has been a positive outcome that in UK and could be implemented in Canada. We need also to provide them mentorship and preceptorship programs as return to work strategies. So retirees that don't want to be used only to mentor others, but also they want to learn, and this is very important to come back to return them to the nursing profession. And the third point is integrate internationally educated nurses who are presently in Canada. So as you know, in 2020, the International Council of Nurses have released a report and have raised an ethical concern regarding the equitable distribution of nurses between high and low income countries. And this is very dangerous because the nursing shortage is a global. So we need to focus on international educated nurses who are presently in Canada by facilitating and fast-tracking the immigration process, the registration process, and also the employment and integration process. So now if we move to the third R, which is recruit and mentor, we suggested to focus and expand domestic training programs by increasing the number of seats in local nursing training programs. But before doing that, we need to focus on and increase on the nursing faculty capacity. So if you don't have enough nurses, faculty, who can train these nurses? This is very important. As you know also that the population in Canada is a diverse population, so we need to diversify the nursing workforce in order to provide and to respond to the needs of this population. We suggest forming partnerships with Indigenous and Black nursing organizations, as well as implement holistic admissions review and expand the French delivered nursing programs in Anglophone provinces. We need also to support trainees to work in underserved communities and sectors. Here, as you know, like there is a big issues in rural and remote areas, and we don't have enough nurses, and there is like inequitable distributions of nurses and healthcare workers. So we suggest to scaling the students' loan forgiveness and also implement the employed student nurse program in different provinces. And also we suggest other promising solutions, including offering tuition nursing programs so we can attract people to study in nursing programs when it's free, and also scale the Ontario Nursing Graduate Guarantee Program. So as you can see, the three R's are very important, but the first R, retention, is very important. So retention, then retention, then retention is very important as the cornerstone to attract people, because when we retain and we improve the work conditions for health workers, we can return the others and we can recruit to attract nurses when the conditions are favorable. So if we move to the next slide here, as you can see, we have in order to help the federal government, the provincial territorial governments, and employers to implement these solutions, we have created this infographic. So as you can see, for each R's, for example, to support health work retention, the federal government should set standards for minimum care health worker and patient ratio, for example, and so on. For the provincial territories, they need to scale the retention initiative that we have suggested in our report, and with target investments. And for employers, for the first R, they need to foster more safe, healthy, and supportive work environments for all the healthcare workers. So this is the infographic that is very important to take into consideration. As you can see here, the solution are a set of solutions. We cannot like pick up what we want and then we play it. No, we cannot fix the problem like that. Otherwise, we're gonna have the same vicious cycle. We need to implement all these solutions. But this is not enough because we need proactive solutions. And now I invite my dear friend Arthur to talk about the proactive solutions.
Thank you very much, Houssem. So good morning to everyone who's west of me, and good afternoon to everyone who's east of me. So what we're talking about this morning, I should introduce myself. Sorry, I'm Arthur Sweetman. I'm at McMaster University, and I hold something called the Ontario Research Chair in Health Human Resources. And much of my day is spent thinking about issues with health human resources and big data. So I can go to the next slide. So the idea that we're thinking about here is embedding planning, enhancing data, and enabling access to forecasts. So what we really want to be thinking about in this part of the presentation is how we could use data, how we're not using it as well as we could at the moment, how we could use data to improve planning and to improve outcomes for nurses. Can we go to the next one? So just to begin with, to give a big picture, the massive scale of the health workforce is well known. More than 10% of all employed Canadians are working in healthcare. Healthcare The pay that goes to the health workforce represents about 2/3 of all healthcare spending, and healthcare spending was about $175 billion in 2019, which is about 8% of everything that's spent in Canada. So the healthcare sector is massive. But what I want to do is contrast that to health workforce planning, which I think is very modest by comparison. I think all jurisdictions in Canada would benefit from enhanced data collection on the health workforce, enhanced capacity to both analyze health workforce data and to plan. And I'm arguing, and I think a number of people on this call would agree, that we want an institutional body, a council or an institute, we can pick different names to support this activity. And the key goal here is to make this a regular body, something that exists, that's going to do it when it's popular to do it and when it's not popular. In fact, as we know right now, health workforce planning is an important issue for governments and they're focusing a lot on it. But if we had done health workforce planning properly in the past, then it wouldn't be at the top of the agenda. It would be one of these background things that nobody thinks about. And that's what we want. We want a body that is so successful that we don't even know that it's working. It just works in the background, and health workforce works very well and smoothly. Can we change the next slide? So what we've been doing, in my view, in the past number of years is muddling through. And muddling through is not a plan. The thing that ministers are discovering, and they discover, each generation of ministers discovers it afresh, is that health workforce adjustment takes a long time. So if we think about the years of training required for different health practitioners, so 2 years for a registered or a licensed practical nurse, 3 to 4 years for a registered nurse, 5 to 6 years for a general or a family practitioner, and 9 to 11 years for a cardiologist. You can't just turn on the tap and create health professionals. And then beyond new trainees, health workforce planning needs to better consider career pathways. So often when we talk about health workforce planning, we're talking about how many people graduate. But for nurses, we need to think about an entire career pathway. We need to better integrate large-scale system-wide issues with local employer ones, which is to say we need to have people in ministries talking to people working in hospitals and clinics. We need more integration between those. And we need to better reflect the interdisciplinary nature of care in our planning. We need to build that into what we plan. Can we turn to the next one? And we were arguing a few weeks ago to the ministers of health, and I think I'm still arguing, or I don't think, I know I'm still arguing, federal funding and support is useful for planning. So the provinces need some support, but most of the work has to happen at the provincial or territorial level, right? Provincial and territorial ministries of health currently undertake health workforce planning, but I argue that their data and analytic capacity is limited, and the legislation and regulation regarding health workforce data needs attention. And again, a federally funded council or institute that provides a point of contact and support for provinces and territory workforce planning, I think would be a good investment. We need to expand data collection, data warehousing, and data analysis. We need especially to increase stakeholder engagement in planning, execution, and feedback, because feedback is a really important part of planning. And I would like to see this ideally formalized as a tripartite strategic planning approach, where we bring together ministries of health, worker organizations, and employer organizations to work collectively on thinking about tomorrow. We spend a lot of time thinking about today, but health workforce planning is not only about today, it's about thinking about tomorrow. And we need many, many perspectives and the active engagement on people on many sides to do this planning. Can we go to the next slide? So here's an example of something where we came close to planning in Ontario, but we couldn't quite make it work. So this is an example collected from the College of Nurses of Ontario, which was around December 2020. This is sort of just after the first couple of waves of COVID, when things were pretty bad in many ways. And if we look at this, certainly back up at this stage, there was a little bit of a nursing shortage. It's got worse since then, but we can see that there are a large number of part-time nurses. We can see it in green, and part-time registered practical nurses that wanted to work full-time, but couldn't be matched properly with full-time jobs. If we had better data, more timely data, and if we had good regulation around those data, we could do a far better job of matching nurses together with the jobs they want. Because right now we have a shortage of nurses, and we also have a bunch of nurses working part-time who report to their college that they'd prefer to be working full-time. And yet we seem to have an inability to bring these together. And I think better planning, better data would help us to get better matches to give nurses the type of jobs that they want, that they can excel in. Could we go to the next slide? And here's an example on the other side in terms of physicians. I'm focusing here on physician hours, and we can see the bottom line, the sort of reddish line is female physicians, and the blue line at the top is male physicians. The black line in the middle is both. We can see that over the past 20 or 30 years, physician hours of work have declined appreciably. And one of the things we haven't not taken into account in our planning for physicians is that you basically need about 1% additional physicians each 4 or 5 years just to make up for the loss of hours, because physicians are working fewer hours, right? And it's not that physicians are working few hours. The average physician is still working over 40 hours a week, but they're working fewer hours than they used to. And we need to take this kind of information into account in our planning. Unfortunately, many ministries focus on how many bodies there are, how many heads there are, rather than how many hours people are working. So we need more sophisticated data than we have at the moment. Can we go to the next slide? Of course, there's many other professions. Data collection and planning needs to capture not just physicians and nurses, but we need to think about interdisciplinary teams. We need to think about how these teams fit together. That is to say, we need to think about systems. We need to plan for systems, not occupation by occupation. And we need to think about, as I said earlier, consistency over time in our planning. It's not right now, I'm calling it an enthusiasm of the moment. Everyone's keen on thinking about health workforce planning at the moment, but we need to be thinking about planning when things are going well as well as when things are not going so well. And so there's a lot of economies of scale and scope, which again is why I think a federal agency that helps the provinces they need to do their own work, the provinces, but it helps if it's in sort of a nice coordinated context. Can we go to the next slide? And of course, planning brings economic efficiency as well. So ongoing planning is a hallmark of efficient organizations and systems. And my sense is that at present, health workforce planning is suboptimal. It's siloed. That is to say, we tend to think occupation by occupation. The information on data and data on which it's founded is modest, and the capacity for analysis is limited, especially given the complexity and the size and the importance of the sector. So again, I'm arguing for improved health workforce planning to facilitate coordination and efficient resource allocation, to improve patient access and worker satisfaction. And I think that investments in health workforce planning would have a big return if it's done well. Thank you very much. I think that's the end of it for me, and I'll hand it over to Ivy.
Great. Thank you so much, Arthur. So I'm going to be discussing now what would this council or set of coordinated activities for the health workforce actually look like. And so we're talking about that as being a collaborative. And yes, I must remember that I need to introduce myself. Ivy Bourgeault. I'm a professor at the University of Ottawa, and I lead the Canadian Health Workforce Network with many other folks like Arthur and Houssem. So I want to share with you this quote from Mark Britnell, who wrote this in the text Human Solving the Global Health Workforce Crisis. And this was written in 2019. And at this point, there were projections that there would be a global shortage of health workers of 18 million by 2030. Now, we haven't redone those projections, but let's just say it's probably not any better. Indeed, it's probably much worse. So I'm just going to read this quote for you, and I want to emphasize a certain element. Over the next decade, we are heading towards a global health workforce shortage in healthcare that will harm patients, citizens, and societies. Knowing what we know, we cannot simply watch this happen. We can't sleepwalk through this. And I believe it's possible to make good this gap by orchestrating our policies and practices in a more innovative, concerted, and collaborative way. It will involve the determined and careful coordination of many different agencies, institutions, and organizations which left to their own uncoordinated and fragmented efforts will fail because the size of the challenge transcends any normal linear solution. Now, it's important to note that each of these organizations are doing the work that they are supposed to be doing, but nobody has the job to coordinate this. Hence what Arthur was talking about in terms of a council or institute or a collaborative, a rose by any other name would smell as sweet. So we need to do that. So we need to recognize that there is a broader range of interprofessional stakeholders for us to engage in a much more open and collaborative way. And this is just one depiction of how we could look at that at both the federal or pan-Canadian level, at the provincial territorial level, how they're connected through things like the FPT, Committee on Health Workforce. But this goes across ministries of health, but also labor, education at a national level, at a pan-Canadian level, immigration as well. It takes into consideration particular functions of funding and remuneration of employers. It looks at governance and regulation of regulatory authorities and their consortia. It also takes into consideration the functions of education and certification of the educational institutions, as well as their pan-Canadian accrediting bodies. And then we need to have involved the research and knowledge exchange entities, the Canadian Institute of Health Information, Healthcare Excellence Canada, us, that the Canadian Health Workforce Network, but also the Canadian Institute of Health Research. This is not a new call. And I can list off examples, starting with 2002 from the Romanow Commission, recommending a much more coordinated approach. The 2003 Standing Committee, recommended a much more coordinated approach to health workforce in response to outbreaks. That was at the time of the original SARS crisis, which pales into comparison to this one. And quoting from the 2007 report of the Federal Provincial Territorial, what was called then the Advisory Committee on Health Delivery and Human Resources, which is now Committee on Health Workforce, or CHWN. They said the action depends on the commitment of all involved in making the transition from the status quo to a more collaborative approach. The critical success factors to apply a framework, the Pan-Canadian Health Workforce Framework that they identified, was appropriate stakeholder engagement, strong leadership and adequate resources, a clear understanding of roles and responsibilities, and a focus on cross-jurisdictional issues. And then most recently, the House of Commons Standing Committee on Health called for a health workforce observatory, which is another name that's used more internationally. They called for that in 2010, and many of the stakeholder organizations that we just identified on the previous slide all agreed to that. There was so much consensus to that. And it was also a consensus that we were building with the call to action, for a health workforce agency of some sort. And examples of leading practices exist in other sectors here in Canada, and noted here is the example of BuildForce that has been funded by ESDC, so funded by the federal government for over 20 years to provide labor market integration, training, recruitment and retention advice, and management resources for the construction sector. And so if it makes sense for there to be one in the construction sector that constitutes 7% of Canada's GDP, surely a health workforce, which constitutes 8% of Canada's GDP, is an important case to be made. So based on an inspiration from the Human Resources for Health observatories, these are the types of integrated functions of a health workforce collaborative, council, institute, observatory, is first of all to collect and synthesize and share standardized data. And standardized data is where there can be federal leadership. Number two, develop early warning systems, which was what was called for in 2003 with the Senate Standing Committee. Number three, curate evidence and share strategies in the way that the strategies that Houssem just outlined were curated. How do we spread and scale those? conduct applied research, policy evaluation and analysis, develop partnerships to mobilize stakeholders around policy coordination, and to build capacity and facilitate networking. So we do some of these in Canada, but not in a coordinated way. So let's start first with number 1. So CHWN addresses some of these first functions in terms of collecting, synthesizing, and sharing standardized data. But this is very resource intensive, with data coming from regulatory authorities from the provinces and territories in a very unstandardized way. So it's important to note that this is the pathway of data to go into the Canadian Institute of Health information. They come from provincial regulatory authorities, but it's the provinces and territories that outline what should be in a registry. If the provinces and territories agreed to adopt a minimum data standard for health workforce, these data at CHWN could be significantly advanced, and they could then utilize the resources that they spend on trying to standardize data. And for some professions, all that they can manage is age, sex as a binary, and province. That's it. And so with that level of data, you can't do any of the types of health workforce planning, based on leading practices that Arthur was talking to us about. Number 2, short story here, we do not have any early warning systems due to the lack of ongoing planning. So that's an egregious absence. Now, for number 3 and 6, Healthcare Excellence Canada aids in, health workforce sharing and capacity building, but this could be significantly enhanced through some targeted investments. So they do some of this, but it could really, really be accentuated. They have these tools at their disposal called spread collaboratives, and also the more intensive extra fellowship programs that, again, would do number 3 and number 6. So what would be important here is to build strategically on the promising practices that we found in this report and can be found for other health professional groups, to embed more integrated retention, return, and recruitment plans with targeted investments. So as Houssem was mentioning, we can't just sort of pick things off, cherry pick. We need to have an integrated strategy across all of the different jurisdictions. And so if we could, through federal investment, provide wraparound supports through strategic investments to Healthcare Excellence Canada, through their spread and scale collaboratives and extra fellowships for teams, that we would wrap around this type of support in the different provinces and territories. So this would really build capacity for spread and scale and integrate these different initiatives, of which some of which we summarized in the report. Now, if we move to number 4 and number 6, the Canadian Institute of Health Research funds some applied health workforce research in capacity building, and I'll really emphasize some. And the big but there is, at present, less than 3% of all health services and policy research addresses health workforce issues. And if you see this price tag here of 21 million over 5 years, and compare that with what Arthur mentioned, is the price tag for health workforce exclusively, 175 billion in 2019. And then when you take into consideration that health services and policy research receives less than 7% of CIHR funds, then that makes it just a hair on any kind of diagram. It's a minuscule contribution. So that needs to change. And one option that we could do, again, through strategic federal investment to the Canadian Institutes of Health Research, is to provide wraparound supports, especially around sort of the Triple E initiative that Arthur outlined, embedding health workforce planning, enhancing data, and enabling access. And so some tools here could be established in early career health workforce research chairs. Arthur holds a research chair in Ontario. I used to hold a research chair that was funded by Health Canada in health workforce area. There's a need for many of us across different provinces and territories. Health workforce postdoctoral and doctoral fellows, which could be through the Health System Impact Fellowship Program, and a complementary health workforce integrated knowledge translation signature research initiative. So that we could then, in addition to having wraparound supports for the RRR approach, that we would have wraparound supports for the EEE approach to embed and enhance capacity in each province and territory to support health workforce planning and forecasting based on the types of standards that could be developed at a pan-Canadian level. And finally, the volunteer, I emphasize efforts of the Canadian Health Workforce Network. We do not have core funding, could be supported to enhance the community of practice that we have started to build with many other partners. Some international inspiration, and I know this is a busy slide, but it's in part to kind of give you a sense that there is a lot of investment and a lot of Centers for Health Workforce studies in the United States funded by the federal government. So in addition to federal funding, they apply for NIH funding, National Institute of Health Research funding. They're highly competitive. So each of these health workforce research centers support research that help decision makers at the federal, state, and local levels. And they also do so in a very sector-focused way, which Arthur noted is the leading practice in terms of the way to go. With investments that they have provided to these Centers for Excellence in the United States and specific funds that they've provided to a minimum data standard and a minimum data set, they are able to provide these types of interactive dashboards that are completely open access. You can go in and have a look yourself. And it's mapped out by different sectors: allied health, behavioral health, long-term care, oral health care, primary care, women's health care. And it includes multiple occupations and professions. So it includes issues around sector, it includes occupation, it includes issues of urban versus rural distinctions, but it also gets at geography in terms of US maps. You can drill down to particular states and into census metropolitan areas with what we call chloropleth or heat maps. So you can see how much workforce is in those different regions. We have nothing like this at all. It can also map the supply of health workforce in a way that maps it against what are the demands. And then you can see what the gaps are and how those gaps are widening. And then you have these what if scenarios. Well, what if we increased enrollment? What if we, somehow had a difference in service delivery options? So they have some of those what if scenarios built into this dashboard, but it is a tool that can be utilized to have even more granular discussions. This is inspirational and where we should be able to go with strategic targeted investments. This is just an example of how you can see from the heat maps and by the various states. So to conclude, targeted investments into evidence-informed solutions of both a reactive RRR and proactive EEE basis, enhanced with strategic wraparound supports with targeted federal investments, could invest in building capacity to spread and scale the RRR initiatives through embedded provincial territorial teams and spread and scale collaboratives, and that would be through the Pan-Canadian Healthcare Excellence Canada organization. We could invest in building and embedding capacity for a EEE approach to health workforce planning through strategic targeted investments through the Canadian Institutes of Health Research. And 3, we could invest in building better health workforce data and digital analytics for better FPT decision-making through strategic targeted investments through the Canadian Institute of Health Information. So thank you so much for this opportunity to engage with you. This is a historic challenge. We all need to be involved with this, and we really look forward to dialoguing with you at this point.
Okay. Imagine everyone, if the federal, provincial, territorial governments, health employers, unions like ourselves would have a nucleus of experts like we just had. Maybe we wouldn't be repeating the same errors after errors. As I said, I've been doing this job for close to 30 years now, both nationally and provincially, and I've never seen it so bad. But also I get frustrated because we were there in the 80s, we had a shortage. We had a shortage at the end of the 1990s. We were warning that we'd have a shortage, and that's just for nursing. We were warning we'd have a shortage by now, and look what we are at. So thank you to all our experts. I have a list of questions. You really stimulated a lot of information. Naz started it all with part-time, or the new generation of nurses really want part-time work. Let's be clear here. What the new generation, what any generation of nurses want is a respectful job, good jobs, and that respect your work-life balance. A permanent job in Canada is average 37 hours a week. What we need to do is to make sure that we respect the management studies that say we need about 70% of full-time job, about 30% of part-time job, and 10% of casual. That's the good mix that can be sustainable. But if we have bad jobs, of course, nurses and others don't want to work in them. So we need to work there. Julien, my office, put the link of both the French and English report in the chat. One question, Arthur, Ivy, Houssem, was where's the money is going to come from? And what about faculties? Faculties of nursing, faculties of medicine, do we talk about it? So those are the two questions right now. One question was about retention wages, competitive wages. Of course, we're talking about wages. Just look at page 32 of the report. Non-nursing duties, look at page 25 of the report. We totally agree. 30% of our time is wasted. We need to be directly taking care of patients. Good questions about data. How do we expand the data for non-unionized, for smaller facilities such as First Nations? And career paths. I think Houssem talked about career paths in the 3 R's. You know, do we include the personal care workers going up the chain? And the last questions I have right here, how do we push for a chair in research in health workforce? And there was one question on the Coalition of Actions for Healthcare Workers. I'll take that one, Tamara. The coalition that the federal government created is just one more tool. What we're quickly realizing is, as organizations, we have to connect the dots. So we have the reality of the workplace, which I represent for nurses, those realities. We have the evidence, and so many researchers are researching how to do it better. And then we have policy. So how do we connect the dot? Like I say, the coalition is one tool. This is another tool. And hopefully we will come with great conclusions that we can move on. So who wants to handle the questions? The first one was, how are we going to pay for all of this? And faculty, career paths, etc. I can repeat them all, or I can talk for the next 45 minutes.
No worries. I can start first about who's going to pay for this. I mean, our understanding is that the federal government, you know, is willing to be at the table with, and I mean, it's all our funding. It's not like it's provincial funding or federal funding. It's all coming from us, right? Mm-hmm. So, so they want to invest in change, invest in improvements, and our understanding is that, you know, they're willing to be at the table, you know, in that regard. I think that we really need to kind of rethink that any money spent in the health workforce is an investment. It's not just a cost. And, you know, Arthur, you know, can expand on that or disagree with me. But I think that it's important for us to think about that. And we need, you know, I highlighted mostly, you know, what strategic federal government investments would be. That would be tied and ensuring that the provinces are following through on those investments. These are important areas. I can't imagine a province that would legitimately disagree that this is where the money needs to go, although I'm sure that there may be some disagreement. And as well as at the university level. So universities could, you know, request additional funds, but we could also just do things differently at the university. And I'm situated in a university. I know how medieval the institution is and how faculties compete with each other. And I think that we all need to recognize that we also play a role within society, and that we need to say and take a step back and say, yes, I think that we need more nursing faculty. It's very clear. And it's in our own, best interest in that regard. So I'll highlight a couple of those. I can come back to the research chairs, but I want to pass over to Arthur.
So there's two slightly different issues in my mind. One is the need for more money or more funding, and the other is to use the funding that we have efficiently. I think right now we don't use, not as individuals, but as a collective. I'm avoiding using the word system because I don't actually think we have a healthcare system. We have a bunch of people doing things in healthcare, but they're not very well coordinated, and that inefficiency is expensive. I think better planning would mean that we're using the funding we have more efficiently. Having said that, I don't think that the funding we have is sufficient, even if it were used more efficiently. And with population aging, we need regular increases over time in healthcare spending to take care of an aging population. And where that money comes from, at the end of the day, I don't actually care if it's from the federal or provincial government, because like Ivy said, there's only one taxpayer. And whether it comes from your provincial taxes or your federal taxes, I don't think many people care. What they care about is good quality healthcare, and they care about a well-operating system that's using their tax money efficiently. So it's clear we need more tax money, and I think better planning would help us to use that tax money more efficiently.
Thank you. Yeah, no, it's all about what you're reiterating. It's, comes from one pocket. How do we spend it? How do we spend it efficiently? And honestly, if we'd stop making the same mistakes of 30 years ago, we would be saving money. Houssem, you have something to add? Yep.
Yeah, maybe you could add something about faculty. So we have presented like Ivy, Kate, and I will present at the Canadian Association of Schools of Nurses about faculties. So the shortage is not only for registered nurses like who are working in hospitals, but also we have shortage in nursing faculty. And we have shortage in nursing faculty, we cannot train new nurses. That's why when we suggest to increase the nursing seats, we also need to increase nursing faculty to train these nurses. And we also reduce the workload that nursing faculty are feeling. So we have suggested some solutions. One of them was like to hire more nursing faculties, and also to take advantage of people or nurses who have PhD in nursing to work in nursing faculty by streamlining their processes, and even work partnership between universities and regulatory bodies to offer them, for example, a specific license. So this could respond to what we have suggested in the report to increase the nursing seats. This has like some solutions that could be implemented as well.
Thank you. Anybody want to comment on IENs and ethical recruitment?
Yep. Yeah, I can go there. I mean, it's the reason why I started with Mark Britnell's quote. This is a global health workforce shortage that was prior to the pandemic. Pandemic by definition is global. Every country is short, some in much more severity than us. This is what we call a wicked problem, right? I mean, Houssem outlined that at the outset. It's wicked and it's spiraling down, and we have to interrupt that. And we have to interrupt that with the resources that we have here. And so it's a wicked problem that doesn't have just one solution. And one of those solutions is not international recruitment. We've signed on to a 2010 code in that regard, which says we should focus on getting our own house in order. We have a lot of work to do that. We've provided suggestions and very concrete examples of what can be done. We tried to be as concrete as possible, knowing that sometimes pointy-headed academics are not, but we've really, really tried to be very concrete. Do we integrate internationally educated health professionals who are here? Absolutely. They are part of a local Canadian focused solution. And that's egregious, that we haven't been integrating them in the way that they should. And yes, I appreciate that this is a gray area, but I think that if we could focus more, This was what we signed on to in 2010 with the Global Code. This is what we signed on to as a country in 2016 with the WHO global, like, human resources for health strategy, is that we would improve data, that we would actually do planning. We've done none of that. And we just simply put in one lever, increase international recruitment or increase seats, or we reduce that. That seems to be like the one lever that we are trying to operate a complex adaptive system. It's frustrating to see over decades.
Thank you, Ivy. And you'll see in the chat that our ICN, International Council of Nurses, are putting all the information. I remember when ICN passed their position on ethical recruitment, we all signed on to it thinking we'll really never need it that much. And look at where we are now. So questions on scope of practice. Yes, I didn't find it in the report, but we're addressing the scope of practice, really looking at what we're supposed to do and how can we work better in a team. So that's all in the report, just don't know which page, so don't worry there. The question, this study, and that was in the Q&A, this study, is it approved, supported by Health Canada? I'll keep my comments to myself. I'll let one of you wants to jump in.
Health Canada was not the commissioning organization for this report. I could imagine that it would be very useful for their deliberations. I will take off my hat. That was one of the consulting authors of this report, and I will put on my hat, and Arthur also has this hat, as a member of the Canadian Academy of Health Sciences. And retention and support is one of the core elements of that report. And Arthur and I co-led a working group specifically on planning. And that was in response to questions that we received from Health Canada. I'm not speaking out of turn, all of this is public. And so I suspect that there would be alignment in what they would like to do with it. I mean, we're all solutions focused, right? We need solutions. We brought together some solutions. We think that they're doable, practical solutions. And, you know, do we need to enter into a dialogue about how to implement them? Absolutely. But let's get started on that.
Yeah. Yeah, and I think that that's the key. It's all part of the dialogue. And I guarantee you, everyone at Health Canada, everyone in Ottawa has a copy of the report. And they've been receiving advanced copy, even when it was still in draft and a few typos here and there. We were pushing it out because we're in a health human resource crisis and we needed to push out. So more information to come on that for sure. A question on how can we get the federal, provincial, territorial government work together. I'm not going to ask the panelists to answer that question. I think it's public pressure, and it's happening now. We thought it was going to be when our seniors were attacked during the beginning of COVID. Now it's our children. So people are realizing that we need to pay more attention on how we deliver and how we take care and analyze our healthcare system. Standardized data, that question is coming often. How do we regulate? How do we bring, what's the first step to have standardized data? So I'll let you there. And on the retention recruitment initiatives, they exist everywhere. We're about to produce another report on what's going on across the country. But sadly, it's a hit and miss. And why it's a hit and miss, and I can understand every premier, every minister of health being so frustrated because they're trying a bonus here, an initiative there, and they throw it, making sure, trying to make it stick on the wall. But there's no central body, there's no based on evidence, there's no analysis, what you need today and what you need tomorrow. So this is why this report is so important. So on standardizing data, how do we help the regulators of the world standardize data? We have about 6 minutes left.
Okay, so Canadian Institute of Health Information has refreshed their health workforce minimum data standard earlier this year. That could be adopted. Arthur and I, and Houssem is also part of that project, a CIHR funded project in partnership with the Canadian Institute of Health Information to enhance that data standard even further. If the regulatory authorities agreed to adopt the standard, and I appreciate the complexities of their data collection systems, and that's costly. And again, if a standardized portal for health workforce data could be created, and again, another really important area for strategic federal investment, so that all of the different regulatory authorities could adopt and adapt it as they needed, streamlining data collection and data, passage through to CHWN, so that they could then, do much more in a much shorter time frame, and much enhanced decision-making tools like the ones that I showed you in the United States. And I have other slides about Australia and that sort of thing. So this is not just a US thing. Yeah.
Okay, the question that kills. How do we push for a chair in research in health human resource or health workplace?
Oh, there shouldn't just be one. There should be many chairs.
All those PhDs, eh?
No. We absolutely need to build capacity in health workforce research. We are so behind other countries. And we've lost really, really good people. So we need to shift people in the same way that Arthur was a labor economist. I was like a sociologist who studied, the history of professions. We've pivoted. We can have other people pivot, and they need to be all across the provinces and territories. CIHR is really receptive for this right now, but they need to get funding from the federal government. So, I mean, if you push for that, if anybody here is a member of an institute advisory board at CIHR, push really hard, send messages. Rick Glazier at the Institute for Health Service and Policy Research is spearheading this initiative. They are ready for this, but they need investment.
Yeah. They need the push. And there's also the fact that we need to make health human resource or the health workforce sexy again. It's a topic that is so important. yeah, but when you're working in it, I guarantee you don't find it too sexy. It is hard, but how do we promise that it will change? How do we push it? And it is by the evidence. It is by bringing the experts together and having the proper data, but the proper strategies. People say, Linda, you're talking data. As I'm talking data, but it has to be matched with proper retention, return, and recruitment strategies to make sure that we're well linked and that we look at the future. So that's quite exciting. And governments are open. We're meeting with every level of governments. They're really open. They probably just don't know what to do first. So looking forward, a great ADM, I'm not going to name her. She says, Linda, we have a 2-year period. 2-year period to turn this around. So any of you who knows a politician, a policymaker, or a researcher, knock on their doors and make sure that we're working together to fix this, what I call this mess, but to give the hope and the energy to the healthcare workforce that are there day in and day out. And that's our job here. Ivy, Houssem, and Arthur and I, we're very lucky. We work in an office, we work too many hours, but that's okay. We are not in the trenches like our healthcare workers, like our nurses, like our doctors. And that's why we're spending so much energy doing this. So I thank all of you for joining us today. I should look, if no, excellent presentation. The comments are just going. Thanking the three of you on how great this presentation has been. I always laugh. You ask a group of researchers to do a report. There's 50 some recommendation. CFNU put it on one page, and then I saw some put it on infograph. He knows I'm going to be asking for it so we can present it to government. But these experts are also going to be producing more articles, more op-eds to continue putting the pressure. And I ask all of you to do the same thing. And it's December 2nd. So I guess I can wish everyone a happy holidays, des joyeuses fêtes à tout le monde. Et s'il vous plaît, si vous avez besoin de l'information, vous avez le courriel à Ivy, vous avez notre information, gênez-vous pas. If you need any information, Ivy left her email there. You have CFNU's email. They'll send you everything you need, the ammunition to really fight this battle and make sure we win. So un gros merci, Megwish. Thank you, everyone.
Bye.